Good day, ladies and gentlemen. My name is Michael Wang. I'm the Putin Clark Endowed Professor in the Lymphoma Myeloma Department at the MD Anderson Cancer Center, Houston, Texas. Today, it is my privilege to discuss the BTK inhibitors in mantle cell lymphoma with you. Most recently, in the past 20 years, there has been extensive research and especially in the translational research effort that led to approvals of many agents in relapsed mantle cell lymphoma. We started with the bortezomib, lenalidomide, and the peak of the chemo-free therapy started with the approval of ibrutinib in November of 2023, followed by a second generation acalabrutinib and zanubrutinib of covalent BTK inhibitors. Then we had a breast carbologene autoleucel CAR T-cell therapy that has become available to patients in July of 2020, followed by a third generation BTK inhibitor called pirtobrutinib, a reversible non-covalent BTK binder of the BTK protein. Then most recently, this year in May, lysosyl carbologene and maroleucel, another CD19 CAR T-cell therapy, became available to our mantle cell lymphoma patients. I'm very proud of our center, the MD Anderson Mantle Cell Lymphoma Program of Excellence, who led 5 of these approvals. So there are so many agents and novel therapies in mantle cell lymphoma. We started with the chemotherapy. We are moving to CAR T-cell therapy, bispecific, trispecific antibodies, immunotoxins. So there are so many of that, but today's focus is really on the BTK inhibitors. As we know, BTK stands for Bruton's tyrosine kinase, which is a very critical link of the B-cell pathway, B-cell receptor pathway. That is all the B cells and including malignant cells depend on to survive. If you inhibit this critical enzyme in the cytosol and the BTK protein and the BCR receptor pathway gets interrupted, the survival line gets stopped, and the malignant lymphoma cells would not survive. Unfortunately, this is also true in some of the B cells, but we believe that the mantle cell lymphoma cells are especially sensitive over the B cell sensitivity to the inhibition of BTK protein. So far, we have 4 generations of BTK inhibitors. First generation was the covalent irreversible ibrutinib that's approved and by FDA in 2013, and together with many clinical trials using this compound. Unfortunately, due to the lack of a survival advantage in SHINE study, ibrutinib has been withdrawn for mantle cell lymphoma in the U.S. It is still available actually outside of the U.S. The second generation, including acalabrutinib, zanubrutinib, another non-approved agent called orelabrutinib, showed very good data in mantle cell lymphoma, not approved yet. And then the reversible non-covalent BTK binder, including pirtobrutinib, approved, and also ARQ and vincabrutinib in clinical trials. The fourth generation, we have a BTK degraders that's currently in clinical trials with none of the agents approved yet. SHINE study was this international study after the approval for ibrutinib, and then it was designed to in the SHINE study with ibrutinib plus BR in untreated mantle cell lymphoma, published in New England Journal of Medicine. This trial, as you can see, have 2 arms. And the first arm with the ibrutinib arm, including BR, rituximab maintenance with ibrutinib until progression or intolerance. The placebo arm include BR plus rituximab maintenance, but with a placebo instead of ibrutinib. Here's the patient features of the trials. As you can see, in the ibrutinib and the placebo group, all the features are quite similar. The primary endpoint was the PFS, and this PFS was significantly different. As you can see, the 2 curves separated nicely, with the ibrutinib curve showing median PFS of 80.6 months versus only 52.9 months in the placebo group. This is statistically significant with a significant p-value and odds ratio of 0.75. Therefore, this SHINE study was a positive study. It met the primary endpoint. If you look at the blastoid morphology, there was a little actually significance of the ephemeral arm over the placebo arm, that the median PFS was 25.6 months versus only 10 months in the. So this three drug combination with ibrutinib BR is actually better than BR alone in blastoid pleomorphic histology. This is very important in the community when you are facing these issues with the blastoid pleomorphic. If you want to use the BR, please consider adding a BTK inhibitor. So on the right, you can see the p53 mutation, unfortunately, showed no significant difference statistically, but numerically, it was significant with a PFS 28.8 months versus 11 months in the placebo group. The overall response rate was similar, 89.7 versus 88.5%. The time to next treatment was also very significant with ibrutinib over placebo group. If you look at the side effects, you can see that the majority of the side effects, grade 1 or 2, shown in light blue and light green. With the deeper dark blue and dark green showed the grade 3 or higher side effect, which is not very prevalent. How about the bleeding? Bleeding was much more in the placebo group, 42 versus 21. Major bleeding, 5.8, 4.2. Atrial fibrillation, please remember, 14% with the ibrutinib group versus only 6.5. So atrial fibrillation is one of the most feared side effects of ibrutinib. That is one of the main reasons why ibrutinib is withdrawn from the U.S. market. Hypertension and also arthralgia happen a little more than in the ibrutinib group. The key point of the trial is the overall survival was overlapping on each other, actually with the odds ratio 1.07. This is the reason why FDA and the company withdraw the drug from the market, is that although there was a significant PFS benefit, however, the overall survival was not significant and it was not different at all. Conclusion is that this outside of the US, this is a meaningful clinical minimum PFS survival. However, the overall survival had no change. So that was the SHINE study. The ECHO clinical trial, which presented by myself in EHA 2024 this year, showed that how about with the same design of a trial, just replacing ibrutinib with the acalabrutinib, therefore the ECHO trial. As you can see, that there's a very much similarity between ECHO and SHINE, almost nearly identical. In the placebo, in the acalabrutinib group, there was BR with R maintenance plus acalabrutinib. In the placebo, BR with R maintenance plus placebo. Very different from the SHINE clinical trial, that the crossover is allowed in the placebo group. If the patient developed the progressive mantle cell lymphoma, relapsed mantle cell lymphoma, they could receive acalabrutinib, actually supported, made available by the company of AstraZeneca. As you can see, the patient features of the two groups are very similar. The overall response rate is similar to SHINE study, was also similar between the two arms, 91% acala versus 88% placebo. But there was major difference in the PFS, just as the SHINE study. The PFS median for the acalabrutinib group was 66.4 versus only 49.6. As you can see, the two curves separated nicely. The p-value was significant. The odds ratio was 0.73. So very importantly, those progressed on mantle cell lymphoma, among 99 patients who progressed or relapsed on the placebo arm, 69% received the BTK. Even with the CT, almost 70% of a placebo arm crossed to the acalabrutinib arm, the overall survival are still separated. meaning that concurrent therapy with a collagen bendamustine rituximab is potentially superior than sequential therapy compared with the BR then at relapse use acalabrutinib. So remember, concurrent therapy, acalabrutinib, BR should be used upfront together. The overall survival very significantly different from the SHINE study is that there's a trend for overall survival improvement. There could be a trend to improve further because this curve only represents 1/3 of the patient, and we 2/3 of the patient are still waiting to aid in for the overall survival curve. So there's also a possibility of a further improvement. And you can see the median for overall survival has not been reached after 45 months. And also you can see that the odds ratio of 0.86 and the p-value is not significant. Here is the time emerging AEs. As you can see, in the grade 3 and above AEs, a little bit more with acalabrutinib, and also more deaths, 12% versus 10%, not statistically significant. And SAEs included 69 versus 62. TAE leading to acalabrutinib placebo related to versus is 68% versus 56% in the placebo, is therefore adding acalabrutinib brought about more TAEs, which is treatment emergent adverse events. TAEs leading to acalabrutinib or placebo discontinuation had 42% versus 31% more in the arm of acalabrutinib. This is a very important slide on adverse event of interest. Remember, in the SHINE, atrial fibrillation was twice 14% in the ibrutinib versus only 6% in the placebo. Here you can see the atrial fibrillation in the acalabrutinib was 6.1% versus 4.4% in the placebo, not statistically significant. This is why acalabrutinib has much less atrial fibrillation side effect compared with the ibrutinib. Therefore, acalabrutinib survives in the treatment options in the mantle cell lymphoma. Hypertension 12.1 plus 15, actually more in the placebo. Major bleeding 2.4 versus the 5.4, in actually more in the placebo. Infections 78% per 71, similar, but a little bit more in the acalabrutinib group. Secondary malignancies 9.8% versus 10.8% in the placebo arm. So please remember, there's no significant difference between the two arms on secondary malignancies. Median time to treatment was actually more in the acalabrutinib, indicating that good tolerance versus 25 median for the placebo. A lot of people ask me, Dr. Wang, shall we use BTK inhibitors forever? Are there any duration of therapy that's actually fixed, and we should learn from the data, right? So, if you remember the SHINE data, the median treatment duration was 24 months in each arm. Here you can see the median duration also around about 1 year, 29 months to 25. Personally, I believe the optimal duration of therapy with the ibrutinib in combination with another drug is between 2 to 3 years. Of course, you have to individualize the patients. Some patients may have more side effects, some people may have less side effects. How about the deaths? 97 patients died in the acalabrutinib versus 106 died in the placebo arm. As you can see, the placebo arm mainly the death is mainly due to the disease progression. 14% in the placebo, much more than the 10% in the acalabrutinib group. In conclusion, ECHO study showed a very significant PFS and a very good trend towards overall survival benefit, although no statistical significance. In my opinion, ECHO clinical trial is a positive clinical trial and should be a global new standard of therapy for older patients with newly diagnosed mantle cell lymphoma. So how about the triangle study? So both the SHINE study and the ECHO study are studied studies for new patients who are actually older than 65. But in the triangle, what about the younger patient, less younger than 65? So we have the triangle study. Please also remember age at this time of our therapy for mantle cell lymphoma is very important. We arbitrarily separating the older patients, where older patients over 65, and usually they are not able to tolerate the intensive therapy, such as autologous stem cell transplant, hyper-CVAD. So, but in the younger patient, triangles in the younger patient, intensive therapies such as autologous stem cell transplant, followed by 6 cycles of induction therapy, or using 6 to 8 cycles of hyper-CVAD. In both therapies, it has been associated with the overall survival of over 12 years. Therefore, in young people, we used to use very intensive therapy. However, intensive therapies can save the patient life, but it can also, the intensive chemical therapy does not only attack the tumor DNA, but it can also attack the whole genome of the human body, all the cells. Therefore, secondary malignancies are underestimated and underestimated and underreported, and it is a very significant issue, especially when our patients are surviving a longer period of time. In some of the studies, hyper-CVAD or autologous strategy have only about 5 to 10 years of follow-up. Their secondary malignancy could be between 15% to 20%. So if with a longer follow-up, you can imagine it could be a very significant problem. And also chemotherapy related secondary malignancies are usually rapidly lethal. Therefore, it's a significant problem in our time. The triangle study is a European study, is the largest study ever conducted, phase 3 study in mantle cell lymphoma. As you can see, it has 3 arms. The first arm, called the control arm, uses 6 cycles of R-CHOP alternative RDAP therapy for 3 cycles, followed by autologous stem cell high dose therapy with autologous stem cell transplantation, then observation. So in the second arm, arm A plus I arm, is the using ibrutinib to add to the induction therapy to the R-CHOP portion for 3 cycles, followed by stem cell transplant, and then followed by ibrutinib maintenance for 2 years. In the third arm is the I arm, which has the 6 induction therapy R-CHOP with RDAP, and with the ibrutinib added on the R-CHOP for 3 cycles, then followed by 2 years of I maintenance. Please note that in the third arm, there was no autologous stem cell transplantation, no high dose therapy. Each arm, about 50% of them, received the rituximab maintenance. So as you can see, this is a very well-designed study aiming to study the role of ibrutinib maintenance versus autologous stem cell transplant. As you can see, the primary endpoint of failure-free survival, FSS, was superior with any arms added with ibrutinib maintenance. The standard control arm with 6 cycles of RDAP, R-CHOP, followed by autologous stem cell transplantation, was the worst in terms of PFS. So even the I arm, remember the I arm without the stem cell transplant, which is shown here in the gray, the gray curve, is superior statistically than the arm without ibrutinib but with the stem cell transplantation, as shown in dark blue. And this is statistically significant. Please also note that if you do add the ibrutinib to the stem cell transplantation, it also have a superior FFS curve. Therefore, this is a positive study. The overall survival, although not statistically significant, but also indicated that the gray arm with ibrutinib without a stem cell transplant is better than the stem cell transplant arm without ibrutinib maintenance. So, in my opinion, this study changed my practice of not using stem cell transplant upfront. I'm in favor of the chemotherapy induction followed by rituximab and ibrutinib maintenance. Of course, in the US, ibrutinib is no longer available. I usually substitute ibrutinib with acalabrutinib or zanubrutinib. So transplant studies, the SHINE study and the ECHO study, which is a positive study, especially the ECHO study in the older people, but they still have chemotherapy bendamustine in it. And in the triangle study, although we got rid of the autologous stem cell transplant, if you agree with the triangle conclusions, but the study still have the regimen still have severe, very intensive cycles of chemo induction therapy with rituximab alternating rituximab DAP therapy, intensive therapy with high dose ARC. Could we have a completely chemo-free option of not using chemotherapy at all? So there's numerous studies. For example, the AVR study, which includes acalabrutinib venetoclax rituximab study, this only have the frontline patient. As you can see, the overall response rate was 100%, with a CR at 90% in this small trial with 21 patients. So this indicated that the three drug combination could be very powerful. So as you can see, the median follow-up in this trial was 20 months, and you can see the progression-free survival is very prolonged, and 1 year free 90%, and the overall survival also looks similar. So another study conducted by the Cornell University Hospital, led by Dr. Ryan Jia, who is an MCL expert. Her study is frontline, include acalabrutinib plus lenalidomide and rituximab. This is also called AR2 clinical trial. As you can see, among limited patients, there's a 100% overall response rate, CR of 83%, the median follow-up of 23% months, and this is also has high efficacy. And you can see the median with a median follow-up of 23 months, the progression survival and overall survival also looks promising. How about the bovine study? The bovine study is performed by Dr. Kumar and colleagues in Memorial together with another institution in Boston. As you can see, they used the zanubrutinib or obinutuzumab venetoclax only in p53 mutated patients. As we can see, although the number of patients are small, but among the patients with p53 mutations, the overall response was 96% with a CR at 80%. Both the SHINE study and the ECHO study in older people with a BR plus ibrutinib or BR plus acalabrutinib. But there's also a study called Mantle study, which is completely chemo-free at the front line, you older patient with mantle cell lymphoma, newly diagnosed. The combination was zanubrutinib versus the rituximab plus acalabrutinib versus bendamustine rituximab, and this trial has finished enrollment, and we're looking forward for the readout in next year or the year after. So how about for older people who who have low risk disease, who may not able to tolerate 3 drugs? As you can see, in our single center study at MD Anderson, led by my colleague Dr. Jang and myself, we have the rituximab ibrutinib study with a good response rate. However, and also good PFS and overall survival. However, the RR study have a atrial fibrillation rate of 24%. So learning from that mistake, we then did another study with replacing ibrutinib with acalabrutinib. As you can see, the overall response rate was 92% and CR was 74% in the intended to treat population. If you look at the total population non-intended to treat, the overall response 92, CR 92%, and after a median cycle of 16 cycles. I think the AR therapy is already in the NCCN guideline and is a very benign combination in place of BR, bendamustine rituximab. So here is the AR study follow-up, and you can see the PFS and the overall survival are reasonable. So how about in the relapse setting? In the relapse setting, first they had a combination of ibrutinib combined with the venetoclax in patients with relapse refractory mantle cell lymphoma. This is the primary data on the simpatico study. As you can see, the simpatico study is also a multinational, multi-center randomized double-blind study. The ibrutinib arm was combined with the venetoclax arm, and versus the ibrutinib with the placebo arm. And you can see the patient features between the placebo arm and the experimental arm are quite similar. The primary endpoint was investigator assessed the PFS, progression-free survival, which was significantly improved in the ibrutinib versus plus venetoclax arm versus ibrutinib plus placebo arm. As you can see, the two PFS arms separated nicely, clearly, with the ibrutinib venetoclax arm meeting PFS at 31.9 months versus only 22.1 months. This difference was statistically significant with a p-value of 0.005 and a hazard ratio of 0.65. How about the time to next treatment? It was also very positive in favor of ibrutinib venetoclax versus the ibrutinib placebo. The CR rate was numerically high in the ibrutinib venetoclax arm at 54%, and statistically significant, only 32% achieved in the placebo arm. The duration of response was also significantly different. As you can see, the overall survival numerically improved, but not statistically significant. So the side effect, as you can see, in the grade 3 and above AEs was at 84%, versus in the ibrutinib venetoclax IV arm versus only the placebo, 76%. Serious AEs was unequal, 60% each. AEs leading to continuation, 36% in the placebo arm. AEs leading to reduction, 36 to 22. Of course, more in the ibrutinib venetoclax arm than the placebo arm. AEs leading death, 16 versus 14%, similar. And also on the right, you can see the most common side effect of the AEs for ibrutinib venetoclax combination in relapsed mantle cell lymphoma included diarrhea, neutropenia, nausea, fatigue, and anemia. So how about the PFS? PFS without COVID-19 case. As you can see, if you censor the COVID-19 cases, the PFS was even more significant and statistically significant, with a median 36.4 months with 22 in the placebo. The overall survival also was not significantly affected censoring CD19 cases. There's a numeric advantage without statistical significance. In conclusion, the simpatico study is a positive study. It should be a new international standard therapy in relapsed mantle cell lymphoma in countries outside of the U.S., since ibrutinib has been withdrawn from the market. And Amy Anderson in my center have an ongoing trial with a collaborative modality venetoclax, and I'm looking forward to share this data in the future. So we have talked about the first generation, 2 generation of BTK inhibitor. How about the 3rd generation, the reversible non-covalent binding of BTK inhibitor, including pirtobrutinib, which is the only drug in this class approved by FDA. As you can see, this trial enrolled 134 patients with a standard population of relapsed mantle cell lymphoma with a median number of prior therapies at 3. Therefore, this is a previously heavily treated population of relapsed mantle cell lymphoma. Despite those, you can see the overall response rate in the patient who was exposed to BTK was 59%, with CR at 25%. As you can see on the left side of the waterfall plot, that the majority of the patient enjoyed a tumor reduction. However, if you look at the 11 patients who had never received the BTK, the response rate was 82% with a CR of 18%. Please remember, This is due to the cross-resistant activity between the covalent BTK that were used prior to the non-covalent BTK inhibitor pertobrutinib before in the clinical trial. So if you use the prior BTK inhibitors, covalent BTK inhibitor, the response to the pertobrutinib was only 51. But if you have never used the prior BTK inhibitor, the response rate is 82. This data might be solidified by ongoing phase 3 study, which used a pertobrutinib in the relapse setting without prior BTK exposure. The pertobrutinib duration response with the median was 8.2 months. Actually, with a limited follow-up, this number could improve with time. And how about the pertobrutinib safety profile? As you can see, no DLTs was ever reported on any of the phase 1 studies. 96% of patients received a pertobrutinib dose and at 200 milligram daily. 1% permanently discontinued. So this is a very low. As you can see, the AEs of interest, the fatigue was 23%, very low, diarrhea 19%, less than the prior BTK inhibitors, covalent BTK inhibitors. Neutropenia was low. And look at the atrial fibrillation was only 2%, basically equal to the study population at the baseline with no added among 600 patients. So pertobrutinib so far has not been attributed to be associated with the severe cardiac toxicity on the time-limited follow-up. If you compare the ibrutinib, acalabrutinib, zanubrutinib, 3 BTK inhibitors covalently, you can see the atrial fibrillation rate is 11%, 2%, and 2%. So in the future, when we have more follow-up, we will put pertobrutinib on the right side to compare. So how about the BTK degraders, the fourth generation of BTK? So, whenever you use covalent BTK inhibitors, if you have mutations, if you have a mutation with the one covalent BTK inhibitor, the other two covalent BTK inhibitors do not work. Pertobrutinib can overcome prior BTK mutations, but the response was only 51%. Could we actually get rid of the major part of BTK protein, maybe overcoming all the mutations and cause even more efficacy and less toxicity? So BTK degraders has been studied in a bunch of clinical trials. Unfortunately, none of the trials have given any specific single agent activity in mantle cell lymphoma. So to give you an idea about how BTK degraders work, basically you can see on the left side, there's the Li3 ligase, which is connected to the ubiquitin by ubiquitin conjuncting enzyme, E2. So this, on the right is the BTK. In the middle is the chimeric. What is the CDAC? Chimeric degradation activation compound. As you can see, this chimeric with the linker. On one side of the chimeric, there's E3 ligase, which combine with the E3 ligase. When this happened, and the BTK ligand will bind with the BTK, as you can see, once this combination binds, the ubiquitin will be transformed to the BTK protein, where it's polymerized, and then this polymerization of ubiquitin will lead to proteasome degradation of the BTK, and releasing the E2, E3 compound to bind to initiate the process again. In this part, we can degrade the BTK protein. Therefore, we can achieve the BTK inhibition in a brand new way. And we're looking forward for the future study for the data coming. That's data that's coming with mantle cell lymphoma, with monotherapy in mantle cell lymphoma.
Can you kind of tell me like how you visualize the pathophysiology of mantle cell lymphoma and like where BTK fits in? I mean, I'm a very simple person who went to med school 100 years ago, so, whatever, but I think I understand like EGFR mutations in lung cancer as a simple concept of a mutation that leads to uncontrolled growth. You put in an inhibitor. Is that does BTK fit into that type of model, or how do you visualize it?
So you imagine the BCL receptor pathway is a pathway that started with the BCL receptor on the surface of the B cell, and this pathway is linearly transfer the important biology signals through this pathway, one chain, all the way leading to the nucleus. but where the action actually, whether the cell to divide, to survive, or actually to die, is is all these actions starting in the nucleus. But along the signal, but the signal has come from the surface of the cell, and the signal has to be transferred to the nucleus. But along the chain of the signal transduction, there's very critically a protein called BTK. If you knock that BTK or inhibit the protein, you interrupt this signal, and the survival or not survival signals cannot be transferred to the nucleus. The cell the cell will go through apoptosis, the cell death. This is how you imagine the whole BTK protein and BTK inhibitor work.
Let's go with your cases. I was thinking these really look fabulous the way you put it together.
Case number one, an 80-year-old man who has a history of mantle cell lymphoma for 15 years. He received hyper-CVAD in the past, thalidomide rituximab, bortezomib, followed by R2 rituximab, lenalidomide, and currently on zanubrutinib. Unfortunately, he has been diagnosed with the MDS due to the extensive chemotherapy in the past, lung cancer due to excessive smoking, and gradually developed a bloody pleural effusion in both sides. So what should we do at this time? Put a Demo catheter to drain the bloody effusions. A, transfuse platelet since the platelet is only 40, so that the patient may slow down the bleeding. Number C, resect the lung cancer mass in the left upper lung as soon as possible. And C, stop zanubrutinib. All those may appear to be practical, but what I did is stop the zanubrutinib, which is the easiest one. We all know that the BTK inhibitors, every one of them inhibit platelet aggregation and leading to longer bleeding time. It functions similar like aspirin, and the side effect is like aspirin. If you don't cut yourself, there's no bleeding. If you cut yourself, the bleeding will be brisk and prolonged. So please remember, BTK inhibitors, especially in older people, you have to warn them not to fall. Quite a few older people have died after fall and sustained a intracranial bleeding and died from that fall. So this is one of the major side effects. Please remember, the simplest thing, first, before you do anything else, stop the BTK inhibitor. So case number two, a 70-year-old man with a history of mantle cell lymphoma that relapsed after chemotherapy who was started on acalabrutinib. During the first week of therapy, he developed a mild headache, scoring about a 2 to 3 out of 10. So what are you going to do? A, treat headache with ibuprofen. B, stop acalabrutinib and treat with aspirin. C, switch acalabrutinib to zanubrutinib. D, hold acalabrutinib until headache is resolved and restart at a reduced dose. And E, hold acalabrutinib until headache is resolved, then restart at the same dosage.
So I'm surprised you didn't start some caffeine, have him drink coffee on that list.
I agree, Dr. Love, and if you allow, we should add that option as F. So, so what I did is hold acalabrutinib until headache is resolved and restart the same dose. To be honest with you, many of the other choices are correct, but what I did is that, so the majority of the headaches last 2 to 5 days is self-limited. You don't ever need to reduce the drug acalabrutinib. Please remember, all the BTK inhibitors, only acalabrutinib is associated with increased rate of headaches. So this is usually self-limited, and you do not have to reduce the dose. Number one. Number two, yes, the best therapy is, as Dr. Love said, is drink some caffeine. And another good drug is Furosemide that actually have Tylenol and caffeine in it, is very effective, right? But the key, you can treat it with a Tylenol. You can also treat it with ibuprofen, and you can also, you don't usually switch the zanubrutinib in the first week of the drug, right? Ideally, you don't treat it with aspirin because acalabrutinib is already a bleeder. You treat it with aspirin, you actually increase the bleeding time. So that's the case number 2. Case number 3, a 60-year-old man presented to your clinic with a newly diagnosed mantle cell lymphoma, CLL type, with positive cyclin D1 but negative SOX11. His bone marrow is infiltrated by MCL 60%. His spleen is so big, it's 25 centimeters, and his peripheral blood white cell count is 100,000. Please remember, by medical school, whether you attended medical school 100 years ago or 2 years ago, the WBC should be less than 10,000. So here we have 10 times the normal, 100,000. So number A, start acalabrutinib to treat the mantle cell lymphoma. Number B, start rituximab in the outpatient clinic followed by adding acalabrutinib. Option C, admit the patient to the hospital, start rituximab at 25 ml per hour without escalation, and then add acalabrutinib after 4 doses of rituximab. C and D, start zanubrutinib, and E, start pirtobrutinib. In my original study, I presented the phenomena called compartment shift phenomena. So the compartment shift phenomena are associated with all the BTK inhibitors, and it's not only limited to mantle cell lymphoma. It's also can occur in CLL and other, and for example, idelalisib can also do that. Kinase inhibitors. So what it did, it's the BTK inhibitor could drive the cells from their originally tumor environment, for example, in the bone marrow, in the spleen, and detach them and drive them into the peripheral blood where circulation is very fast. And these cells are circulating, driven out of the microenvironment into the blood, are away from their home environment in terms of nutrition and growth signals, and are programmed to die. So remember, all the BTK inhibitors can do that. So you have 100,000 already. When you have extreme lymphocytosis, you have hyper viscosity due to increased cells in the blood. At this time, this number you could already have a PE, and those kind of patients with high dose lymphocytosis, I always do a VQ scan on it to exclude the PE. Very important. You need to look into the patient fondi to see if the fondi is bleeding, because hyperviscosity lead to that. Remember, when the hyperviscosity with the Waldenstrom's lymphoma, we always look into the fondi to look for bleeding. And you also ask the patient about bowel ischemia, diarrhea, bleeding, and you also ask the patient whether they are slow they have a TIA. So this is very, very important, right? So you need this patient need to start from pheresis and then followed by slow rituximab. If you do acalabrutinib, the acalabrutinib will make the cells even higher. You may trigger a acute bleeding even in the brain. So very, very dangerous. For the same reason that zanubrutinib do that, even the most recent pirtobrutinib reversible BTK inhibitor also do the same. So you never start with this, right? So you only have a B and a C. Then you start rituximab in the outpatient clinic. Wrong, horribly wrong. Remember, MCL is different than CLL. The density of a CD20 in the CLL is not very dense. Says rituximab does not cause tumor lysis too much. In mantle cell lymphoma, where the CD20 is the most dense among the B-cell lymphomas, if you treat, they are so sensitive to rituximab, you can send them into severe hypersensitivity, severe hypotension, severe actions. You can actually kill the patient. So if you want to do the rituximab in the outpatient, you need to fractionate. You need to do 3 doses, divided into 3 doses. In some of the centers, they do that. But at MD Anderson, we admit the patient to the hospital. We do pheresis to lower the count on 50. And sometimes in the hospital, you don't have pheresis ready like MD Anderson. You do slow rituximab, my friend. You put the patient in the hospital. If the patient have cardiac, you have to monitor their heart telemetry, right? You do rituximab, but don't escalate. 25 ml, you may still have severe reactions where even at 25, you have to stop. If you don't ever escalate in the first dose, Then when after 4 doses, the lymphocytosis practically will resolve, then you can add BTK inhibitors. This is very, very important. This is a life-saving phenomena. This is often tested in the board. Case number 4. A 45-year-old gentleman with advanced stage mantle cell lymphoma. His past therapies include induction chemotherapy followed by autologous stem cell transplantation, Revlimid rituximab, R2 therapy. Please remember, Revlimid is the academic name is lenalidomide. So lenalidomide rituximab, ibrutinib venetoclax, as indicated from the sympatico study, GemOncs, bendamustine rituximab, CAR T-cell therapy, and allogenic transplant. Unfortunately, he relapsed with a bulky tumor mass of 15 centimeter in the abdomen and another bulky mass in the lateral to the right thigh. So this patient had received practically everything, but he's still 45, right? So this patient is already chemo resistant. Can you do ESHAP, RICE, and chemotherapy to bridge to the bispecific antibody trial? Remember, bispecific antibody or some combination of immunotherapy is the only chance to rescue this patient. But can you use RE by RICE? I would not. The patient is already chemo resistant after allogeneic transplant. Okay, numerous chemotherapies before. So how about the rituximab with high dose cyclophosphamide dexamethasone in the B choice? Rituximab high dose cyclophosphamide dexamethasone bridge to CAR T-cell therapy. Maybe targeting a different antigen trial. This may be good, but still not the very effective bridging therapy. If you do chemotherapy in the chemo refractory patient, the response could be less than 50%. Discuss with the family and colleagues to arrange hospice. This is reasonable, but it's not what I did. I seldomly give up on any patient if I have any hope. And if the family and the patient are with me to continue to fight. Do an MR of the brain to rule out CNS lymphoma. Very legit, very good choice. But you need to treat the patient. What's the treatment plan? What I did was rituximab high dose cyclophosphamide dexamethasone with concurrent low dose radiation to the bulky masses and then followed by immunotherapy trial. I have done the polatuzumab in combination with the mosunetuzumab in the relapse setting of this population, and the response rate is 75% and CR is 70%. So we do have good options. You have to bridge them into that. How? With a combined chemotherapy with the radiation. Please remember, it may take you 6 cycles to shrink a tumor at 7 centimeter and 15 centimeter with a high dose cyclophosphamide dexamethasone. But if you don't have the luxury of say 15 cycles, you only have a chance for 1 or 2 cycles, please consider radiation therapy. Radiation therapy is underutilized in B-cell malignancies. Radiation therapy, except for large cell lymphoma, all the others, Hodgkin lymphoma, marginal lymphoma, follicular lymphoma, mantle cell lymphoma, myeloma, all respond to radiation acquisitively. So very sensitive to radiation. So you plus low dose radiation, the tumor usually crash for response rate between 90 to 100%. So if you use number E, that's my best choice.
What's happened with the patient?
The patient surviving, we may wanted to survive with the pola mosunetuzumab, and then he went another way to get another CAR T-cell therapy. Wow. So a 55-year-old man with a tear duct blastoid mantle cell lymphoma who has been treated in the community with the rituximab bendamustine. Within 6, remember, you need at least add a BTK inhibitor in this setting. So so remember, if you have blastoid, you treat it with a chemo, the response usually about 50%, and it rarely lasts more than 6 months. This is very important. Could be a board question. Okay, so blastoid, you have to realize that blastoid is a very significant negative prognostic factor, and it has lower responses, shorter duration. Within 6 months, the patient relapsed in the left eye with the eyeball pushed out by the underlying mantle cell lymphoma tumor. Ibrutinib therapy with the rituximab induced the partial remission for 4 months. The tumor has further increasing left eye. 2 days into the CAR T therapy, the whole left eye is swollen, erythematous, and this pain 9 out of 10. So what should we do? Start IV dexamethasone, maybe a good choice. Maybe this is CRS, should we give tocilizumab? C, start high-dose cyclophosphamide chemotherapy because the tumor has progressed. D, admit to the hospital and start intravenous antibiotics. Maybe there's an abscess or something, and start XRT and steroids for tumor progression. Please remember, there's a flares phenomena with the bispecific antibodies and the CAR T cell therapy, because this is a local area. Many CAR T cells and other T cells may infiltrate the tumor and causing the tumor to have pseudo progression. This is a case of a pseudo progression where you start dexamethasone. Tocilizumab would not help. Chemotherapy is wrong. You killed all the CAR T cells. Admit the patient to the hospital, start antibiotic. You totally missed the target. You're gonna let the patient may have, the patient would not start radiation steroids. That's for progression, not good. Start dexamethasone, ideally in the hospital setting.
So that was a fabulous work, fantastic. I learned so much. It was great. Thank you so much. I'm just kind of curious though, outside a clinical trial, putting aside reimbursement, what do you consider optimal first-line therapy in a younger and older patient nowadays?
For the young and fit older patient who's 70, they can still be fit. I started triple therapy with a chemo-free agent with a 2-year or triple follow-up, triple maintenance. So what I do is I do acalabrutinib. I choose one of the BTK inhibitors. Okay, acalabrutinib could be one, venetoclax, and rituximab. After I achieve the complete remission, maybe 6 to 8 months, there will be you have negative PET, negative bone marrow, and negative GI biopsies, upper and lower endoscopies. Okay, when those three are triple negative, I start the maintenance. If the patient has never had any, has no risk factors, I continue triple maintenance at reduced dose. For example, acalabrutinib is 100 twice a day. I only use once a day. And venetoclax, we can use 400, but only maintenance 100 flat. Rituximab every other month for 2 years. Okay. For the moderate, the same. For the high risk factors, for example, they have any of the key ICD over 50, blastoid or pleomorphic, or the p53 mutations or deletions, I would give some kind of a consolidation. Chemotherapy consolidation is the least preferred, maybe bispecific antibody consolidation or some other consolidation. So I have had a very good result, and with very few patients relapsed. But for the older patients who are frail, double combination, acalabrutinib rituximab or zanubrutinib rituximab, and that's my preferred choice.